Hi, everyone. Good morning, good afternoon, and good evening. On behalf of USAID Advancing Nutrition and the University of North Carolina at Chapel Hill, thank you so much for joining us today. This will be our fourth Family Inclusion and Nutrition Through Engagement Community Practice, or FIND COP for short. My name is Neha Jabari. I'm a social behavior change specialist for USAID Advancing Nutrition. And as I said, if you have not already introduced yourself, please go ahead and do that in the chat, including your name, organization, and country from where you're joining. So we're very excited for today's session, which will focus on implementation lessons from engaging family members in nutrition. We will hear from our two speakers, and after which we hope to hear from you all. And we'll leave time at the end for questions and discussion and experience sharing. And I will now take the opportunity to introduce our two speakers for today. So first we have Sujata Singh, who is a gender equality and social inclusion specialist for USAID-funded Suaahara program in Nepal. She has more than a decade of experience working in development sector and providing strategic leadership in integration of gender and social inclusion in multi-sector programs, male engagement, violence against women, social norms change program designing and implementation, and monitoring and research. She holds a master's degree in anthropology from Tribhuvan University in Nepal. After that, we will hear from Dr. Lydia Clemmons, who is a senior advisor in social and behavior change communication with the Manoff Group. She's a medical anthropologist with 35 years of experience in the design, management, implementation, and evaluation of nutrition, agriculture, nutrition, HIV/AIDS, maternal and reproductive health, child survival, livelihoods, food security, primary school education, and social behavior change communication programs in more than 20 countries in Africa. Her experience includes extensive work in collaboration with both multilateral and bilateral donors, including USAID, CDC, UNAIDS, UNFPA, UNICEF, WHO, and World Bank, as well as host country governments. She has worked as a senior manager and consultant for both international and local NGOs. Throughout her career, Dr. Clemmons' technical experience has supported the development and the use of evidence-based state-of-the-art tools and interventions in social and behavior change, which have been consistently recognized as global best practices. Dr. Clemmons has a Doctor of Philosophy degree in medical anthropology from the University of Pennsylvania, a Master's of Public Health degree from the University of Michigan School of Public Health, and a Bachelor of Arts degree in human biology from Stanford University. So now, without further ado, I will turn it over to Sujata to bring in her presentation.
Hello, thank you so much, Neha.
I'll share my screen.
Can you?
Yes.
Can you listen to me?
Yes, I'm sharing my screen. Just give me one moment.
Okay, great.
Neha, do you need me to share it?
Yeah, please go ahead. It's not showing up on my side. Thank you.
Okay, thank you. Thank you so much, Neha, for the introduction and for also putting up my presentation. I think considering the time, I would like to start from the slide number 3. If you can go to the. Yeah, one more, yes. Thank you so much. First of all, I would like to say namaste to everyone, and I'm very excited to share about our implementation learning from Suaahara II program, where we have engaged family members to improve health and nutrition program. So before I start, let me briefly give an overview of Suaahara II program. So Suaahara II is, which I'm currently talking about, is built on the Suaahara I, which was implemented from Suaahara 2021 to early 2016. Basically, Suaahara is a multi-sector nutrition program that operates at scale in 42 districts of Nepal to reach over 900,000 households with 2 million women and children in 1,000 days period. That means that women from that means from pregnancy through child into the 2 years of old, 2 years of age, to improve their health and nutrition status. In 2016, in the fall of 2016, Suaahara II strategy transition from mother-child-dad focus to family approach, recognizing the potential of engaging the family members in improving maternal child health and nutrition. This strategy was informed by learning from Suaahara I implementation, as well as learning from early Suaahara II formative research that was conducted in 2016, and that found that in the most of the household in Nepal where this formative research was conducted, it said that, even though the mother was primarily responsible for the care work, she had to ask for her husband and the family members for permission for every kind of a resource utilization, and also for the recommended behavior to practice into her everyday life. In the same research, mothers also said that, programs should also involve their husband, mother-in-laws, and the father-in-law, as they hold household resources and influence the decision that they make. Additionally, Suaahara's early annual survey 2017 also suggested that there is a huge knowledge gap between 1,000 days women and her husband and family members, which also suggested us to engage family members into our overall intervention. Next slide, please. Yeah, to save this family approach, Suaahara tailored its intervention with SPCC approaches and trained all its frontline workers and the staff on especially working with the family members, particularly targeting fathers and father figures. And also we developed a program guideline and also a toolkit to provide comprehensive interpersonal communication with family members instead of only focusing on mothers. Likewise, Suaahara II program also prioritized community engagement and mobilization, especially adopting Jesse Champion approach and training fathers from 1,000 days household and mobilizing them in community through peer-to-peer outreach approach. For fathers collective action, the Jesse Champion fathers also led a fathers dialogue group in the community to discuss about social and gender norms, maternal child health nutrition, and other nutrition related topics. Next slide, please. Additionally, Suaahara also adopted media approach to engage family members. Suaahara's flagship radio program called Banchin Ama radio program was revised in 2017 to include more family characters in drama to appeal to the whole family members. Later, Banchin Ama radio program was also expanded into social media, targeting migrated family members because we found that a lot of family household, not a lot, but around 32% of family members are migrating into the program implemented district. And similarly, Suaahara II also designed a card called Letter to My Father in a format of a letter from unborn child to a father asking for his greater support in overall childcare process. And it was provided to the father by through the health facility during antenatal care visit, and also through the community fathers dialogue group. And likewise, Suaahara also adopted SMS mobile phone technology, let's say, and with the SMS, and we sent out this SMS, especially focusing on nutrition and gender related roles to all household head. And additionally, short videos were also developed focusing on fathers and fathers' role, and these videos were screened especially during the community events where fathers dialogue group were happening or the mothers dialogue group were happening. Next slide, please. Yeah, in this you can see the pathways for how we conceptualize this overall father's engagement and the family engagement process. So because I already talked a little bit about this, I want to focus more on these 5 major areas where Suaahara envisioned while engaging fathers and family members. We particularly identified 5 major areas where we encourage all fathers and family members to ensure, like, in the household, to provide that kind of environment where women could eat diverse and adequate diet, women could rest during the pregnancy, how fathers and family members can accompany pregnant women to visit antenatal care, and also to ensure that they share their household load so that they have a adequate time for breastfeeding, and also something like that. This kind of 5 major areas of action we identified where they could support. Next slide. In this slide, you can see that the results so far after having a tailored family inclusion intervention of Suaahara II program. The data shows that these multiple interventions help to create an awareness and increase the knowledge of the father and the family members on their role to improve maternal child health and nutrition. Suaahara's annual survey data 2017 versus 19 shows that, which you can see over here also, that targeted family intervention contributes to improve the household members' knowledge, and that also could help to translate into practice as well. This gradual but significant association indicates that it is both important and possible to engage family to improve nutrition related behavior. Next slide, please. Yeah, so overall, overall, the learning is that it is we felt that it is very important that we integrate gender transformative approaches to the designing of the family members engagement intervention, because it is very important that we focus on the self transformation of fathers and family members to challenge the norms, and also challenge the norms, and to do that critical reflection, they also need some specific or separate safe space where they can come together and have a open conversation. So having a separate space for a father is very important, and understanding the flexibility of time in terms of their availability, because they have a lot of family responsibility and making a living or earning. So this kind of understanding should be consider while developing this kind of a safe space for fathers or mothers separately. And along with that, building capacity of staff to engage family members are critical to address their own biases, because as these biases could prevent them from engaging family members critically in norm changing intervention, because we know that these staffs will also be from the same community where these norms are already engraved. So having those kind of like intensive staff's capacity building to overcome those biases is very important. That's what have been our learning. And similarly, working with local government is very, very important when we are talking about family engagement, because it helps the ownership of local government of this kind of approaches, as well as it helps the scalability and sustainability of the family approach. And as we know that like family members, especially particularly fathers, they face a lot of stigma and backlashes from their peers for involving into maternal and child nutrition behavior, because they consider it as a mother's domain only. So having the acknowledgement and felicitation from the local government really helps them to establish their credibility or the work that they are doing in the community. So so working closely with the local government is very important when we are doing with the working or engaging family members. Similarly, we found that migration is a big challenge, especially when we are talking about engaging family members. And it has been even more big challenge after the COVID situation. But what has Suaahara's learning been is that, having an interactive social media or say virtual platform like Vanchinama radio program, which we turned out to the into the social media platform, helps this kind of a platform helps the migrated fathers to engage and influence their behavior and as well as their resources. So this has been our very nice learning that how we can target those migrated fathers as well through this kind of a social media platform. And along with that, we also feel that, we all know that, when we are engaging with the different family members, it will obviously take additional time of our frontline workers to reach to these different people into different timings. And it takes time, it takes like double or triple kind of a different SMSs to send to different people. And we also need different kind of SPCC materials to targeting to these different family members. So it means that these whole things really calls for a resource. So there are sometimes it could be a resource implication when we are engaging with the family members. So these are another aspect that we really need to consider while we are targeting or engaging family members. And lastly, changing norms and behavior really takes time. Therefore, along with this short-term message-based intervention, it is very important that we also have a long-term tailored intervention which will help the effectiveness of family inclusion in a long run. So I think next slide, please. And I will stop here with this sharing. And if there's any questions and confusion, any questions, I will be happy to answer.
Wonderful. Thank you so much for that, Sujata. I think it really helped us get a deeper understanding of Suaahara's approach. And for those on this call who have engaged with family members, I'm sure those reflections resonate with them. But I look forward to the discussion that will come after our next presentation. So thank you again. And now I will turn it over to Dr. Clemmons. So over to you.
I'm sorry, I had my mute on, so let me start again. Good morning and good afternoon and good evening, everyone. It's really a pleasure to be here. I hope everyone can hear me and maybe not see me. My name is Lydia Clemmons, and I'm going to be talking about a couple of programs in Tanzania and Ethiopia. The Manoff Group has had really the privilege of a decade of learning and work in 2 countries through 2 generations of multi-sectoral flagship nutrition programs. In Tanzania, the first generation was the USAID Mwanzo Bora nutrition program in 2011 through 2016. And then the follow-on program, USAID Lishe Endelevu, which is still running right now from 2019 to 2023. And in Ethiopia, the first generation program was USAID Engine from 2011 to 2016, and then USAID Growth Through Nutrition 2016 through 2021, which was just wrapping up, and I believe is doing a sort of 5-year assessment of everything. We learned a lot over a decade, and I think many of you have as well. Back in the first generation of these multi-sectoral programs, everyone was trying to figure out, what does integration of nutrition and agriculture look like? How do we do this? There was a lot of learning going on. And what was wonderful is with having a foot in both countries, we were able to do a lot of cross-country sharing and learning as we implemented with our lead partners. This is just a quick example of Growth Through Nutrition, which was the second generation USAID multi-sectoral integrated nutrition approach. I'm sure this kind of results framework looks familiar to those working in USAID. In terms of research, again, we piggybacked and learned from both countries. In Tanzania, we had very little opportunities to do solid research. A lot of it was very rapid. There were a lot of desk reviews. We did landscape analysis and gender analysis. And in Ethiopia, though, we really got a chance to do more deeper qualitative research, including trials of improved practices and a series of formative research, qualitative research efforts. The research studies that are highlighted here are the ones I wanted to say are just different and offered a lot more insights than I think we might normally get. Concept testing is a personal favorite of mine, a type of research that comes after your formative research, before your materials development, and before any kind of pre-testing. Concept testing is really just testing ideas, especially creative ideas, for how you want to present information and speak to your audiences. Other interesting things done in Ethiopia, I just want to flag an observational research study on household wash practices and cultural resource inventories. I'll speak about those in a moment. So some of the findings that came out from all of these various types of researches in both countries, these are just a few of them, that pregnancy is not considered anything special, and that's true in either country. Women eat the same as everyone else, that heavy workloads limit women's time to rest and eat nutritious food. And particularly in Ethiopia, this sense of selflessness. While the maternal health nutrition recommendation is telling pregnant women or breastfeeding women, eat an extra meal, women feel very ashamed and reluctant. They really feel embarrassed about the idea of having an extra meal, because in resource limited families, that means you're eating more than everybody else, or you might be depriving your children or your husband of extra food because you're eating it. So women were really reluctant to follow that recommendation of eating an extra meal. The best time during the first 1,000 days is the postpartum recuperation period. That's when the whole family rallies around the woman, lets her have some time to really rest after birth, after delivery, and have special foods, and everybody's chipping in to help with her chores and taking care of her. And it's a lovely time. Unfortunately, only lasts sometime between a week and 14 days. If you're really lucky, maybe a month. And then it's back to normal. Also, as Sujata had mentioned, I believe, paternal grandmothers, women's mothers-in-laws, have a lot of clout with them and with their husbands, the sons of the mother-in-laws. And then men's roles are to protect and provide and decide for the family. And of course, there are some barriers around that role, as well as wonderful opportunities. Husband support, couple relationships are very important influencers. And of course, love for the child and aspirations for a happy family are important motivators. And then another finding was just that everyone is involved in some form of childcare, whether it's family members, neighbors, everyone is chipping in. And so these findings did move us away from focusing exclusively on the mom as the care provider and really looking at everyone else who was having a role in providing care. For example, in Ethiopia, with the observation research that we did on wash practices, a wonderful technique was shadowing children. Just for 5 or 6 hours, just follow that child, the life of the child, follow them everywhere they go. And you see that children are handed off from mom to older sister, from older sister to grandpa, from grandpa to a neighbor, and back to mom. And so these are all opportunities for improved nutrition practices and caregiving that have been overlooked in many nutrition programs. So our SPCC strategies in both countries, based on the research, really focused on nutrition as a family affair and really focusing on the key roles of mothers, fathers, and grandmothers, as well as focusing on families as units and on couples as units. We developed first 1,000 days parent support groups meetings where mothers met together, dads met together, and also grandmas met together in what Sujata had referred to as safe spaces, where people with their peers could actually talk about and practice gender transformative skills without fear of being ridiculed or being embarrassed because you were with your peers and you were all trying these things together. In Ethiopia, because we had the added challenge of introducing adolescent girl nutrition into our programming, we decided, you know what, we're going to talk about the whole household and nutrition for the whole household, where nutritionally vulnerable household members might benefit a bit more, but all household members benefit some. And then, of course, the development of multimedia SBCC kits that were focused on family roles in nutrition were a big outcome of these strategies. I had mentioned creative concepts. I'm just going to go briefly. We tried to find family-friendly, easy concepts for nutrition. And for the first 1,000 days, we broke it down into 4 stages. And since these were agricultural communities, both in Tanzania and Ethiopia, the idea of breaking the stages down by the growth of a sunflower became a concept that we tested and proved to be very effective and user-friendly, and people understood it and found it attractive. Looking at the first 1,000 days across 4 different stages of child growth and nutrition. We also focused in Ethiopia on this issue of women's selflessness and looked around for creative concepts that we tested in communities and came up with the idea of the queen bee. In Ethiopia, honey production is a major activity. And when we asked about the queen bee, everybody immediately understood the link between how the hive cherishes its queen bee and how families can cherish their pregnant and breastfeeding women. And so this queen bee concept was eventually developed into SBCC materials and messaging. And I'll talk more about that in a moment. But again, the idea is the family is the hive, the pregnant and lactating woman is the queen, and let's do what the bees do everything we can to support her. We also, through the SBCC strategy and thinking about the research, came up with the idea of we behaviors, which are those supportive actions for family members. Back in the 2010, 2011, when all of this was starting, there was a lot of talk in the nutrition community and SBCC community about key behaviors. And key behaviors always focused on women and what we wanted women to be doing. We behaviors were the behaviors focusing on family members and peer groups. What do we want husbands to do? What would we love grandmas to do? What would we love for families to do to support mom? In terms of the SBCC materials that were developed, one of the important strategies was to focus on positive role models for couples and couple communication. And so we created a fictional 2 characters, a grandpa figure, Mr. Jumbe, and a mama figure, Mama Rutuba. And we translated those same characters over into Ethiopia as well. These were first developed in Tanzania. But this is a married couple. The grandpa is an agricultural expert, and the grandma is a nutrition expert and a nurse. And we did a series of audio recordings, which were essentially entertainment education, a lot of educational talks about nutrition, and then also modeling positive couple communication. And so the educational talks really didn't feel like education. You were listening in a listening group with your peers every week or so to the conversations and the adventures of this couple. And the modeling that went on was how to talk lovingly, supportively, affirmingly with your wife, and how the wife can also be a bit more assertive with her husband, but still be polite and respectful to her husband. Through, again, the first 1,000 days and the idea of focusing on family members, you'll see we developed a lot of print materials that were based on positive role models of husbands, mothers, grandmas, couples, practicing the recommended behaviors as family units or as couples. In Ethiopia, with a cultural resources inventory, when we were looking around to see what is going on right now in cultures that we should be taking advantage of as opportunities for SBCC, one of the things we noticed was that women take a great deal of pride in decorating their home. And I have never been a fan of posters until I saw this in an Ethiopian home, where women were taking such great pride in finding any poster or decorative poster they could and displaying it on the wall. We subsequently developed SBCC materials and asked women to take them home and display them on the wall. And these posters and positive role model testimony cards turned out to be one of the most effective communication channels that we had. They sparked dialogue in the family and also with visitors to the home. What is that? What are they doing? Why are they doing that? And that would spark a lot of conversation. People who brought these materials home were members of the family support groups. It's interesting in looking at some of these, again, positive role model testimony cards, which were take-home materials. Women would put them up on their walls. And during the final evaluation, we said, what was the most favorite material that you put up there? Thinking we had no idea what they'd say, but the favorite material for women was the materials that showed men working to help their wives. So that one on the far right with men carrying water and wood was the favorite. And women would say, I didn't even have to say anything to my husband. He'd just see that on the wall, and all of a sudden he'd start carrying wood and water. And that was really amazing. And just the realization for us who are communication people that we shouldn't forget about nonverbal communication and how nonverbal channels can also influence behavior. We don't always have to be talking. We can be quiet and do some nonverbal. So again, in terms of positive role models, some of the findings from the focus group discussions that came out during the process documentation and the final evaluation was a lot of emulation of the positive role models, especially the older couple. I want my relationship with my husband to be like theirs. And this person is referring again to that older couple who came across as a couple in those audio recordings. They help each other, helping each other is blessings from God. It brings household growth. Life will be good. The child will be intelligent. Man says, as a farmer, my wife calls me by saying you. And similarly, I call her by saying, hey, you. But in the case of the virtual facilitators, Ete Bertukan, that's the mom, the grandma figure in Ethiopia, calls her husband by his name. And she says, Aya Mulat. And Aya Mulat calls his wife by her name. And he says, Ete Bertukan. And this has influenced me, and I'm happy to be like them. Now, this finding was a surprise to us. Even those of us who were Ethiopian intellectuals hadn't realized that in rural communities, in families, husbands and wives traditionally don't call each other by their names. They just say you or my husband. They don't say Beth or Mary or Jill or John. They say you. And so listening to the positive role models call each other by their names was a bit shocking and interesting. And men were reporting that they tried it. When they went home, they'd try it and just for a change, just tried calling their wife by her name. And it provoked a lot of excitement. The woman was really happy. Suddenly they were talking. It was really an unexpected result. Another comment from a grandmother listening to those positive role models, audio recordings. Oh, that couple, they're so committed to each other. The husband consults with his wife. The wife consults with her husband. The husband says, please, Ete Bertukan, let me talk a little. And by turn, she also says, I am Alat, please let me talk. And so they were listening carefully to the tone and the affection and the communication between the couple and emulating that and practicing at home. So an important finding that you'd think this has nothing to do with nutrition actually has everything to do with nutrition. These small acts of affection that were modeled in our positive role models, calling each other by their first names, eating food from the same plate, making coffee, hugging children, improved relationships with the spouses, improved couple communication, improved family dynamics, and appear to correlate with improved nutrition and wash practices. Here's another example of just some SBCC materials with role modeling in family peer groups. People would role model and practice different types of communication skills. And during the question and answer, I can talk more about these or send information if anyone wants to see these role models, but these are called Discuss and Decide Together role play cards. And this is an image of a father's group where they're role modeling how to talk to your wife, depending on the type of communication that's symbolized by those animal photos there. So we're getting into some of the findings. In Ethiopia, for example, this was some of the responses. We had also songs about the queen bee, if you recall, which is promoting supportive family actions for pregnant or breastfeeding women. And there was really good understanding of the song and understanding of what behaviors were being promoted through the song. And here's where we start to get to some really interesting nutrition outcomes, as Sujata was also describing in her presentation. What was most interesting was how much change was happening among men. We were delighted to see this. For example, for maternal nutrition practices, men really changed. And when you think about it, they're the ones who needed to change. They changed their maternal nutrition practices, meaning adopting more supportive actions as husbands and fathers. Changes also happened in terms of the relationships within the family, relationships between the spouses, relationships as family members in general. Again, we see men really were doing the changing as a result of those support groups and the SBCC materials that were focused on men or couples. Men were saying, I really did change how I communicated with my spouse. I changed the relationship with my spouse. I even changed the relationship with my family. And there's a very rich documentation report providing some of the quotes and what people were actually saying to extrapolate on this data here. In terms of nutrition practices, again, looking at baseline and endline findings for those participating in this family approach. This is again from Ethiopia. We see improvements. We see improvements in IYCF practices of women having ever breastfed, early initiation of breastfeeding, and timely introduction of complementary feeding. And then also improvements in maternal dietary diversity scores. Thanks very much, and I look forward to the questions and answers.
Thank you so much, Dr. Clemmons. This was a wonderful presentation, and I think especially the selected findings you highlighted really emphasize the complexity of family engagement and work.